Hello, everyone. My name is Aaron Waxman, and I am the Executive Director of the Center for Pulmonary Heart Disease at the Brigham and Women's Hospital and an Associate Professor of Medicine at Harvard Medical School. We're going to be talking today about new insights in the management of pulmonary hypertension associated with interstitial lung disease, a primer on recognition, severity, evaluation, and treatment. This is not working. These are the learning objectives today. Upon completion of this activity, you should be better able to identify early signs and symptoms and assessments to facilitate a timely and accurate diagnosis of pulmonary hypertension among those patients with interstitial lung disease. You should be able to recognize the impact of screening for mild pulmonary hypertension among patients with interstitial lung disease with the goal of enabling an early intervention. You should be able to evaluate recently reported safety and efficacy data on available and emerging therapeutic approaches for PH-ILD and deliberate on best practice strategies to optimize therapy and improve the quality of life of a diverse group of patients with interstitial lung disease and pulmonary hypertension. So we'll start by thinking about the overview of PH-ILD. And I think with the new definition of pulmonary hypertension that has been included in that definition of pulmonary hypertension in the setting of ILD, essentially any pulmonary artery pressure greater than 20 is considered elevated at this point, and that is dependent on a right heart catheterization. There is no question that when we add pulmonary hypertension onto interstitial lung disease, it makes an already debilitating disease a much more debilitating complication of that disease. And generally, this is associated with reduced exercise capacity, a greater need for oxygen therapy, and a decreased quality of life, and ultimately a worse prognosis. These are the current definitions of pulmonary hypertension. As mentioned, it's a pulmonary artery pressure greater than 20 on a right heart catheterization. We can also think of it in terms of pre- and post-capillary disease based on the pulmonary capillary wedge pressure being less than or equal to 15 to call it pre-capillary or greater than 15 to call it post-capillary. And then fundamentally, it's the pulmonary vascular resistance that is the disease itself, and in this setting, greater than 3 Wood units. And you can see over on the left panel the different groupings based on the World Symposium. And here we're going to be focusing predominantly on group 3 disease in the setting of interstitial lung disease. So when we think about group 3, obviously there are more disease states that fall into that realm. Generally hypoxic lung disease, including chronic obstructive pulmonary disease. Cystic fibrosis can certainly fit in there, and our focus today being interstitial lung disease and pulmonary fibrosis. We can break it further down as far as how the World Symposium has into obstructive lung disease, restrictive lung disease, both mixed obstructive restrictive disease, particularly we think about there the combined pulmonary fibrosis and emphysema, and then hypoxia without lung disease and developmental lung disorders. If we think about prevalence, I think here it's all over the spectrum. We can certainly think of pulmonary hypertension very frequently seen in chronic lung disease, although I think because it's all over the place in the literature, it's very hard to determine an accurate prevalence in this setting. But when we look at the individual disease states, there are certainly lower and upper reported percentages. With COPD, it's as low as 1% and as high as 50%. With IPF, or idiopathic pulmonary fibrosis, the literature would suggest as low as 8% and as high as 86%, and of course sarcoidosis being as low as 6% and as high as 74%. I think the bottom line is when we see ranges like this, we probably are underestimating the prevalence overall. And when we think about the literature that's out there, importantly, when we think about interstitial lung diseases, it's a very wide, broad group of lung diseases, of which there are upwards of 200 different entities reported. The prevalence of pulmonary hypertension is variable among those different entities. And I think a lot of this may be dependent on the type of disease and on the characteristics of the cohort studied, including their disease severity and methods used to make a diagnosis of pulmonary hypertension. And that's really important in that the true diagnosis requires a right heart cath, but many times this is based on echocardiography. There have been some efforts to refine the diagnosis of severe PH in lung disease, and you can see here two conference outputs. The Cologne Consensus Conference describes severe pulmonary hypertension due to lung disease based on a pulmonary artery pressure greater than 35 or greater than or equal to 25 with a reduced cardiac index and a pulmonary vascular resistance greater than 6 Wood units. And fundamentally, the PVR is the disease and really what differentiates the impact of the parenchymal disease on the vasculature versus pulmonary vascular remodeling. And there you can also see the comparative registry data where the PVR was defined as greater than 5 Wood units to define severe disease. And this is clearly associated with significantly worse survival compared to those who have PVR less than 5 Wood units. And it gets even more significant when that PVR goes above 8 Wood units. So just to pause over what we've gone over, I think it's important to recognize the prevalence of PH-ILD has likely been underestimated by most of the studies that are out there. And I think that speaks to, one, how hard it is to find patients early in disease states with interstitial lung disease, as well as once they are diagnosed with ILD, recognizing that pulmonary hypertension may be complicating their progress. A recent study has suggested that using the new definition of mean pulmonary artery pressure greater than 20 will result in a substantially higher number of patients with IPF who have pulmonary hypertension. And given the morbidity, mortality, and healthcare burden associated with pulmonary hypertension among patients with interstitial lung disease, it's crucial to improve screening and diagnosis of PH in chronic lung diseases, and really with a goal to find it much earlier. So let's talk about early recognition of pulmonary hypertension among those patients with interstitial lung disease. Well, first, thinking about the pathogenesis, there's a lot of overlap between both the pathogenesis of the lung disease and the pathogenesis of pulmonary vascular disease, both in ILD as well as in our other WSPH groups. Generally, we're thinking about the role of alveolar hypoxia, endothelial dysfunction, oxidative stress, inflammation, activation of immune pathways, and genetic predisposition, and a spectrum of severity of all of those things driving pulmonary vascular remodeling. Initially, pulmonary hypertension is probably a consequence of interstitial lung disease itself, whereas that disease progresses, it impacts the vascular structures, impinging and causing loss of vascular structures, which will drive up pressure, but probably accounts for mild to moderate pulmonary hypertension. Generally, there's no correlation between the degree of restriction and fibrosis, with hemodynamic parameters indicative of pulmonary hypertension. And really, pulmonary hypertension in this setting is a complex interplay of tissue destruction, inflammation, fibrosis, and hypoxia that exacerbate each other. And there's also a drive for true pulmonary vascular remodeling through various pathways. And it's really a continuum. Patients obviously are dealing with a progressive disease, both the interstitial lung disease and then the vascular disease, such that hemodynamic cut points represent just one snapshot in time. And we have to keep an open mind that as things progress, it's likely that the pulmonary vascular aspects will also progress. There are also challenges with identifying patients who might be at risk for PH-ILD. Really, the symptoms do not overlap. in a clean way. All patients present with shortness of breath, regardless of how extensive one disease is or the other. I think clinical examination also lacks any clear sensitivity to predict those patients who may develop PH-ILD. And what you can see on this graph on the left is that the x-axis depicts time, which is time of progression of their interstitial lung disease, and the y-axis depicts the magnitude of the global symptom burden imposed by ILD and pulmonary hypertension. And clearly, as one progresses, the other starts to progress, kind of trailing that, but both exacerbate the overall symptomatology. So to stop there, just to touch on those teaching points, PH and interstitial lung disease appear to have shared pathophysiology. The pulmonary vasculopathy and PH-ILD should be considered a continuum rather than distinct categories. And lastly, the significant overlap of symptoms between fibrotic lung disease and pulmonary hypertension poses a challenge to identify screening approaches for PH in interstitial lung disease. So now we can think about the consensus approach to screening for PH in patients with interstitial lung disease. First of all, we can think about risk factors. History of pulmonary embolism or heart failure certainly needs to be considered and might steer us in a different path. Any patient who complains of dizziness, palpitations, or syncope certainly raises concern for pulmonary hypertension. As far as signs, I think in general the physical exam can be difficult because clearly the interstitial lung disease itself can affect the physical exam, but generally looking for things that may indicate increased right-sided pressures. As far as testing, this is an important part of screening and risk stratification. I think one of the most important tests is the pulmonary function test, which generally we're going to routinely be getting in our patients with interstitial lung disease. But within that, the diffusing capacity can be very helpful in screening for pulmonary hypertension, especially as that diffusing capacity drops by more than 15% a year or should fall below 40% of predicted. The CT scan can be very helpful looking for right heart enlargement, pulmonary artery enlargement, or an increase in the pulmonary artery to aortic diameter ratio. Oxygen saturation and 6-minute walk tests clearly are measures of progression. They won't distinguish which is progressing, but clearly if they are getting worse and the signs of interstitial lung disease are not changing, it's really time to think about pulmonary hypertension. And of course, the BNP may also be helpful as it starts to rise. And then as far as figuring out whether they do have pulmonary hypertension, it really comes down to clinical suspicion and getting an echo with a high probability of pulmonary hypertension, which would then lead one to do a right heart catheterization. And it really depends on what you see on echo as to how high that suspicion should be. Certainly, if the estimated pressure is increased and there are signs of right heart enlargement, that's fairly easy. It's a high suspicion, but many times the echo is less sensitive in patients with lung disease. So a high degree of clinical suspicion is warranted. As far as concomitant risk factors for development of pulmonary hypertension, this is some data based on a chart review of over 12,000 patients with idiopathic pulmonary fibrosis, of which 3,000 patients developed PH-ILD. There were a number of variables that suggested an increased risk, including the female gender, their presentation being more advanced, history of coronary artery disease, obesity, PE, and atrial arrhythmias all increase the risk for PH-ILD. So to summarize this part, early screening to identify patients with pulmonary hypertension and interstitial lung disease may benefit patients by prompting early treatment and a transplant referral in what is clearly a high-risk population. Routine clinical evaluations and tests assessed for suspicion of PH included signs and symptoms suggestive of PH, CT imaging suggestive of pulmonary artery or right ventricular enlargement, desaturation or changes in oxygen supplementation, pulmonary function test results, particularly that diffusing capacity and the FVC to DLCO ratio, decline in 6-minute walk distance, especially if the lung disease appears stable, and increasing BNP and NT-proBNP levels may also indicate increased wall stress in the right ventricle. If suspicious findings are present, a screening echocardiogram and or BNP should be considered, possibly along with some other tests based on clinical judgment and the patient's specific situation. Fundamentally, though, a confirmatory right heart cath is necessary if any combination of findings raise concern for pulmonary hypertension. So if we consider a case, this is a 64-year-old woman with IPF. She was admitted with pneumonia previously. Her baseline oxygen requirement of 3 liters at rest and 6 liters with exertion. She has been desaturating with exertion at rehab on the treadmill, and she now needs some assistance with her activities of daily living. Just some background, her IPF was diagnosed by VATS biopsy after she had presented with progressive chronic cough and dyspnea for 2 years. Her history was notable for hypertension and steroid-induced diabetes. She had no history of chest pain, palpitation, or syncope. Surgical history was notable for a total abdominal hysterectomy for uterine cancer in 2004, and she presented with lower extremity edema, more fatigue with exertion, and shorter breath with minimal activity such as dressing, showering, walking around the house. Looking at her pulmonary function test, you can see she has a restrictive disease pattern. Her total lung capacity is significantly reduced, and there you can see the DLCO is 39% of predicted, so clearly meeting at that threshold that we talked about earlier. You can see her 6-minute walk test there. She's on 6 liters nasal cannula. Her SATs at rest are 100, but she clearly desaturates while walking. Her distance is reduced at 383 meters and a Borg scale of 4. And you can see what happens with her pulse as she exercises. And there you can also see an elevated BNP. So if we think about our consensus approach, she's kind of hit a number of features on this pathway, including the DLCO, some symptomatology, the BNP, and now an echo would be important to verify that her right side has increased and go think about what her next testing would be. So a discussion question is, what evaluation should we be performing to further examine this patient? And you can see the choices here are CT angiogram of the chest, which would help us rule out venous thromboembolism, an echocardiogram, which would be a good screening test for pulmonary hypertension, and right heart catheterization as a diagnostic test. And the answer here really is all of the above. So we can now look at her CT scan, and you can see she clearly has IPF. And this is based on why she would be getting a VATS biopsy. And here on the CT, you can also see where the pulmonary artery is larger than the aorta, which could suggest pulmonary hypertension. So again, we're kind of heading towards that path of suggesting that she ought to have a right heart cath. So based on this data, what is the level of suspicion for pulmonary hypertension in this patient? I think we've seen a number of features here that would suggest that we really ought to be having a high suspicion for pulmonary hypertension. So thinking about facilitating an accurate diagnosis and the role of mild PH-ILD. So this was an algorithm for diagnosis of PH-ILD, and I think this algorithm really sums things up fairly well. We've already talked about a lot of the symptoms and signs and the pulmonary function test. And this patient clearly hits a number of these features. And now we have the CT scan that raises more concern. And then the next step would be an echocardiogram and then right heart catheterization. But as we think about echo, it actually can be difficult in patients with advanced lung disease. And this is now some fairly old data that suggests that echocardiography, it can be inaccurate a lot of the time. It can often overestimate, very often it can underestimate, and it's accurate about 40% of the time, which really, again, emphasizes the need for clinical judgment based on the patient's presentation. So the teaching point here is a thorough physical evaluation, exercise assessment, computed tomography scanning, echo, serum biomarkers, lung function, and right heart catheterization are really going to be fundamental in the diagnosis of pulmonary hypertension and interstitial lung disease. And right heart cath still is the only way to diagnose and truly risk stratify these patients conclusively. Granted, right heart cath is invasive. It certainly takes some time, but fundamentally it is critical to perform that test. And it's also important as far as differentiating those patients who might have WSPH group 1 or PAH from PH-ILD. So thinking again about our patients, at this point, we would want to proceed with an echocardiogram and right heart catheterization. So these were the echo findings, which are not at all out of the norm for these kind of patients, and it may speak more to the insensitivity of echo in this patient population. But you can see that the right atrium, right ventricle were normal. The right ventricular systolic pressure was elevated. Left atrium and left ventricle were also normal, and the ejection fraction was normal. So the final read on this would be that the pulmonary artery systolic pressure was moderately increased. And now you can see the right heart catheterization, where the RV systolic pressure was 68. It's clearly higher than what the echo predicted. The RV diastolic pressure was also increased at 14. There you can see the mean pulmonary artery pressure is significantly elevated with a normal right atrial pressure, normal wedge pressure. Cardiac output is still preserved, as was the index. And there you can see the pulmonary vascular resistance was quite elevated at almost 7.5 Wood units. So, easy question, what is the diagnosis for this patient? And I think we now have confirmed the diagnosis of pulmonary hypertension due to interstitial lung disease. So how does this impact the patient? I think there's no question in any disease state when you add pulmonary hypertension on, it affects long-term outcome. And here you can see a survival curve based on severity of PH and ILD. The black line at the top are those patients who don't have pulmonary hypertension. And you can see regardless of whether you have borderline, mild to moderate, or severe pulmonary hypertension, outcomes are always going to be more difficult and worse. So let's think about another patient. This is a 65-year-old gentleman with idiopathic pulmonary fibrosis. His symptoms have been worsening, and he now becomes short of breath even at rest and requires more oxygen on exertion. Up hills, he needs about 5 liters, and while on level ground, he needs 4 liters. You can see his history over here. IPF is based on a high-resolution CT scan that demonstrated a usual interstitial pneumonitis pattern, and he presented originally with chronic cough. His history was notable for hypertension. He has no history of chest pain, palpitation, or syncope. Surgical history was unremarkable. He used to walk every day with the need to take breaks on 2 to 3 liters, and that has worsened over time. Eventually, he became short of breath at rest, requiring more oxygen at rest and on exertion. If we look at his data, you can see his pulmonary function testing, again, is consistent with pretty severe restrictive ventilatory defect. His diffusing capacity, though, is kind of in a hazy area. It's not below 40, but it is clearly reduced. And I think the question is that just his lung disease, or could he also have pulmonary vascular disease? You can see his 6-minute walk test there on 4 liters, nasal cannula, Sats at rest 97, dropping to 83 as he exerts himself. His Borg scale is at 6, so a little higher than our last patient. And you can see his BNP is actually well within normal range. This is his CT scan, shows a UIP pattern. And here we can see the pulmonary artery and the aorta. And I think even without the markers, you can see that the pulmonary artery is smaller in diameter relative to the aorta. And here's his echocardiogram, pretty much normal, with an RV systolic pressure estimated at 31 millimeters of mercury. His left ventricular ejection fraction is reduced at 44%. And there you can also see another measure of his aortic root at 4.5 centimeters, which is somewhat dilated. And he did go to right heart cath, and here you can see that his RV systolic pressure was 38. His mean pulmonary artery pressure was 27, which is above our threshold of 20, so he does have pulmonary hypertension. Radial pressure is at the upper limits of normal. His wedge is borderline at 14 if we consider 12 being normal, but again, for the diagnosis of pulmonary hypertension, greater than or less than or equal to 15 is the realm we're looking for. His cardiac output is actually high, which might raise concern about anemia or something else going on. And his pulmonary vascular resistance is really borderline at 2.2. The definition being anything greater than 2 is now considered abnormal, but a patient with interstitial lung disease, as we pointed out earlier, greater than 3. So what is the diagnosis for this patient? And I think we would put him in the category of mild to borderline pulmonary hypertension due to interstitial lung disease. So now we can think about the role of treatment in these patients. Here you can see survival curves in those patients who have borderline or normal pulmonary hemodynamics versus those who have clear pulmonary hypertension. This is back in 2006 when the cutoff was 25 millimeters of mercury. And even at that range, there was a clear difference in survival, which I think is one of the reasons we always want to think about what can we do for these patients. And ideally, we want these dots to kind of be in the same place and try to keep everybody doing as well as we can for as long as we can. And if we think about how the disease progresses, we can really think about these patients as having 2 overlapping disease states. The interstitial lung disease, which we know is progressive, although it's often hard to define the rate of progression, and then the development of pulmonary vascular disease, which also is progressive. So finding that sweet spot where we can intervene on one or the other to slow that progression and improve our patient's long-term outcome is the goal. So now we can start thinking about updates in the treatment of pulmonary hypertension in interstitial lung disease. There's no question there's been a lot of effort to come up with treatment, and unfortunately many of those studies have been somewhat disappointing, really for a number of reasons. Not necessarily because the drugs don't work, but many of these trials did not enroll patients based on hemodynamics. They chose patients based on echo criteria or pulmonary function criteria, and as we've already pointed out, echo is not particularly sensitive, and the pulmonary function also has its weakness as far as saying a patient does or doesn't have pulmonary hypertension. Most patients did not, or most studies did not utilize right heart catheterization. The other thing that limits the utility of these studies is that oftentimes patients have short life expectancy. It's clearly a rare disease, so finding these patients early enough in their course to make an impact is important. And also, I think patients or clinicians generally have a hard time enrolling patients in placebo-controlled trials when patients aren't doing well. These are a number of the studies that have been done over the course of many years now, and unfortunately, most of them have been not suggestive of a good impact, but the one down at the bottom, the INCREASE trial, did show an improvement in the primary outcome of 6-minute walk distance, and has now resulted in approval of inhaled treprostinil for patients with PH-ILD, and we'll look at those results a little more closely. This is the results from the INCREASE trial, and you can see up in the upper left panel there the schema of the trial. Patients were screened and then randomized 1-to-1 to receive drug versus placebo. Patients were titrated up to a goal dose of 9 to 12 breaths of inhaled treprostinil. And you can see down below that schema the outcome, the primary outcome being 6-minute walk distance. And there was a significant improvement in 6-minute walk distance in those patients treated with inhaled treprostinil compared to those maintained on placebo. The safety profile was fairly typical of patients who are treated with inhaled treprostinil. The frequently reported adverse events included cough, headache, shortness of breath, dizziness, nausea, fatigue, and diarrhea. And you can see also up top some of the secondary endpoints as far as clinical worsening was clearly reduced in those patients on inhaled treprostinil. And also we saw a reduction in the NT-proBNP, all of which were significant. Clinical outcomes, clinical improvement, and clinical worsening in patients who were on inhaled treprostinil. One of the big questions was, did dose matter? So we went back and looked at that data and broke patients out into those who got up to the goal dose of greater than 9 breaths versus those who were less than those 9 breaths, and looked at clinical worsening, looked at 6-minute walk distance. And there was a clear difference in those patients who got up to the goal dose, in that it was clearly more efficacious if patients got to higher dosing. So again, the goal is to try to get those patients up to as high a dose as tolerated, with an initial goal of 9 to 12 breaths. When we looked at survival in the INCREASE trial, this is just overall survival, looking at a Kaplan-Meier plot of those patients on inhaled treprostinil in the blue, and in the gray are those patients who were on placebo who later transitioned to inhaled treprostinil. And you can see those curves separate out at just after 12 weeks and stay separated out for the long course of those patients who rolled over into extension phase. And this is a plot using what's called the RPSFT method, which stands for the rank preserving structural failure time. And this estimates the survival time gained or lost by receiving active treatment versus those on placebo. The model makes an assumption that active therapy is acting on longevity by multiplying survival by a given factor once a patient starts receiving the treatment. The factor may be interpreted as the increase or decrease in survival by taking the active treatment compared to the control treatment. And once established, the survival duration of patients is reconstructed and recensored as if they had never received the active compound. And this just emphasizes the survival benefit for those patients who were on inhaled treprostinil versus placebo. This is some work out of the United Kingdom looking at patients who were treated with a PDE5 inhibitor. Now, these patients may not have felt a whole lot different being on drug, but it does suggest that patients treated with PDE5 inhibitor had an improved survival. And the survival difference with treatment was significantly larger if right ventricular function was normal rather than abnormal at presentation. So thinking about an algorithm to consider treatment, again, we look at the diagnosis, those patients with mild or borderline pulmonary hypertension versus those with more severe, thinking about the pulmonary vascular resistance, and you can see a break point there. Those patients with severe, we certainly want to think about referring them to a pulmonary hypertension program and consider parenteral prostanoid versus inhaled. Those patients with less severe disease, we can certainly consider referring them to a center as well where they have experience with these drugs, but certainly you're going to think about inhaled treprostinil for these patients. Certainly think about transplant referral, because ideally we want to get these patients when they're in the best shape possible. And you can also consider a trial of PD-5 inhibitor as well. As far as the guideline recommendations, you can see that for the most part, thinking about the diagnosis and moving towards a diagnosis, thinking about lung transplant, all come with a class 1 level C recommendation. When it comes to treatment, inhaled treprostinil is considered a 2B recommendation and a level B for consideration of treating those patients. However, treatment with ambrisentan, riociguat, and the use of any PAH medication is really not recommended at this time. And just thinking about specifically PAH associated with ILD guideline recommendation, the quality of evidence obviously is very low for PD-5s, and the strength of recommendation is conditional, and you can see what that class and level are. However, with inhaled treprostinil, based on the INCREASE trial, the recommendation is a class 2B and level B. So getting back to our 64-year-old woman with severe PH-ILD, what therapy would we consider for this patient who has confirmed pulmonary hypertension with interstitial lung disease, confirmed by right heart cath? I think the one thing on that list that we would consider is inhaled treprostinil. And what about our other patient, the 65-year-old male who has IPF and borderline pulmonary hypertension? I think there is no right answer to this. I think, though, there is a black box warning with ambrisentan, so we probably wouldn't want to consider that. But we could certainly consider inhaled treprostinil or a PD-5 in this setting. And I think that that really is a discussion between the provider and the patient. So the teaching point here is inhaled treprostinil is the only approved therapy to improve exercise tolerance among patients with PH-ILD. In the INCREASE trial, inhaled treprostinil led to reduced clinical worsening among those patients with PH-ILD. And using 2 independent modeling techniques, we performed a post hoc analysis of the INCREASE trial and its open label extension, and these have suggested a long-term survival benefit associated with inhaled treprostinil treatment in patients with PH-ILD. And obviously, patients should be monitored closely for improvement, certainly for side effects and potential worsening. Endothelin receptor antagonists and riociguat really should be avoided. Phosphodiesterase 5 inhibitors can be considered in severe pulmonary hypertension associated with PH or with ILD. So recommendations to identify patients with PH-ILD that may be candidates for therapy include suspicion for pulmonary hypertension, complicating interstitial lung disease, and should be raised by any of the following. Clearly, progression of their symptoms, worsening of shortness of breath, especially if their lung function is preserved, a low or decreasing diffusing capacity, more frequent desaturations and an increased need for supplemental oxygen, worsening 6-minute walk distance, enlarging pulmonary artery segment on the chest CT relative to the aorta, and certainly echocardiographic evidence of pulmonary hypertension or right ventricular dysfunction. A right heart cath should always be used to confirm the diagnosis of pulmonary hypertension in interstitial lung disease, and then approved inhalation therapy and or lung transplantation can be considered on a case-by-case basis. All right. I want to thank you all for your attention, and I would encourage you to go to the Practice Point website to claim your CME credits and also be able to download the slide deck.